All right, it's 2:01, so I think we can get started.
Hello, everyone. I'm Kimra McIntosh, and I'm here with my colleague Claire, and we're about to start our third webinar. Um, Next slide, please. So just to frame the agenda for today's webinar, so there will be sort of like an overview of parts 1 and 2. Presenter introductions. We'll also be doing housekeeping, and then the presentation follows. So the NYC Health Department aims to reduce suicide deaths and suicide-related behaviors among New Yorkers with a focus on youth of color. To achieve this aim, the New York City Health Department will be creating innovative suicide prevention pilots that serve youth and young adults of color. And then we also have our Care in Transitions, which is a collaboration between the health department, health and hospitals, and the mayor's Office of Equity to reduce suicide-related readmissions to emergency departments for youth in Queens and the Bronx, ages 5 to 17 years old. Next slide. So for today's webinar, which is part 3 of a 4-part series, in part 1 and part 2, we discussed trends in suicide among youth of color. We covered systemic racism. We explored risk and protective factors for suicide among youth of color, and we identified suicide risk among youth involved in the juvenile criminal legal or child welfare systems. The NYC Health Department suicide prevention initiatives are being executed through interdisciplinary partnerships with community-based organizations, researchers, designers, and medical institutions across NYC. And the health department aims to provide enhanced monitoring of suicide as an urgent public health issue, increase and diversify suicide prevention services for youth and their support networks, and expand efforts to mitigate the socio-environmental risk factors for youth for suicide through interdisciplinary strategies. So before I pass it over to my colleague, the health department is also investing in action-oriented research, as I said before, and capacity building efforts intended to raise awareness about suicide risk and protective factors for New York City's BIPOC youth. This is why we are hosting a series of 4 webinars over the next several months dedicated to this topic. And I'll pass it over now to my colleague, Claire Ogburn.
Hi, everyone. Good afternoon. Thanks, Kamar. My name is Claire Ogburn, and I'm the Data and Program Coordinator for the Suicide Prevention Initiatives here at the New York City Health Department. And I'll start by introducing you to today's presenters. So our first presenter is Dr. Erica Bath. Dr. Bath is a child and adolescent, adult, and forensic psychiatrist. And Dr. Bath is a professor and vice chair for justice, equity, diversity, and inclusion in the Department of Psychiatry at the UCLA David Geffen School of Medicine. And she is a senior advisor for the UCLA School of Medicine's Anti-Racism Roadmap. Also presenting today is Dr. Jocelyn Meza. She will help moderate our discussion. Dr. Meza is a bilingual clinical psychologist. She is assistant professor in residence in the Department of Psychiatry and Biobehavioral Sciences at UCLA. And she is the associate director of the Youth Stress and Mood Program and the principal investigator of the Health Equity and Access to Research and Treatment, or HEART Lab, also at UCLA. We also have Dr. Aaron Godfrey with us today, who will help moderate today's discussion. Dr. Godfrey is Associate Professor of Applied Psychology at New York University and Director of NYU's Institute of Human Development and Social Change. And finally, we have Dr. Shabnam Javdani, who will help moderate our discussion as well. Dr. Javdani is Associate Professor of Applied Psychology at New York University, and she directs the NYU Prison Education Program, which expands access to higher education among incarcerated students. And lastly, before we get started, I'll go over some housekeeping items. So this webinar is part 3 of a 4-part series. So after this webinar, you'll receive an email. All registrants will receive an email with the recordings and decks from the prior presentations, as well as the recording and presentation from part 3, and we'll send a registration link for webinar part 4 as well, which is in January. Next, just a content consideration. Our presenters have done their best to use sensitive language in this presentation, but the topic could be triggering. So we will share resources about 988, the Suicide and Crisis Lifeline, in the chat. And you're welcome to reach out in the chat or via email if you need extra resources, and I will put my email in the chat for that purpose. The chat is open and we welcome your comments and reflections there. But if you have questions for the presenters, it would be best if you can use the Q&A function to send in your questions. And after Dr. Bath's presentation, we will do our best to answer all your questions after the presentation. And finally, we'll be sending out a quick survey at the end of this presentation for you to share your thoughts with us. And we would really appreciate if you fill it out so that we can take your feedback into account for the final webinar. And that's all for housekeeping. So I will turn it over to Dr. Bath, who will begin the presentation.
Good morning, everyone, or good afternoon for our New York colleagues. All right, so today we are going to focus on structures and structural and systemic barriers to suicide care. And I think that this is really critically important as providers to really start to beginning to think more upstream, because we can really start envisioning a world where we can begin to remove some of those impediments. Before we get started, I'd like to include a land grant acknowledgement. It is Native American Heritage Month. And so we, as part of UCLA, are a public land grant institution and are on the Anahita territory of the Gabrielino and Tongva First Nation peoples. And so we're paying respect to ancestors past and present. And also just reflecting on my own positionality. Some of you have been along with us on this journey of webinars 1 and 2, but for those who are meeting me for the first time, I identify with she, her pronouns as a Black, cisgender, heterosexual woman. I'm a mother, daughter of physician activists. I've been working in predominantly white institutions and academic medicine my whole career, but also simultaneously working in systems serving youth in the child welfare system and juvenile legal system. I'm an HBCU medical grad and I'm aspiring good trouble champion. All right, so today we're going to review some theoretical frameworks that I think are really helpful in shaping the discussion, examine some of the structural treatment gaps. We'll look at schools as a particular area, and we'll begin to explore some solutions as a prelude to webinar 4, which will be Dr. Meza. Really, I want us to make sure that we're going to be able to identify structural barriers to treatment utilization and understand these gaps, and then begin to understand evidence-based approaches to delivering anti-racist care. And the frameworks that we're going to discuss are structural intersectionality, structural competency, we'll review ecological systems theory, health equity framework, structural racism, and the suicide prevention systems framework. So in my introductory talk, I spoke to you guys about intersectionality, and I just want to review it again in making sure that we anchor this notion of the multiplicity of people's identities, right? So oftentimes people think about race and ethnicity, religious identity, gender as separate, but it's really the confluence of those identities that make a person. And so there's no such thing as a single issue struggle because we do not live single issue lives. And so as we think about barriers, structural and otherwise, to suicide prevention, we need to think intersectionally, right? Also, this notion of structural competency, right? So recognizing that a lot of the barriers actually to people getting equitable suicide care, to getting access to suicide care at all, really lie above the individual level, right? So we think about health inequities and where they fall, they're determined by social drivers, which are often determined by policies, economics, systems, and social hierarchies structure. So these are the drivers. So really sort of taking this approach, and as providers, actually beginning to make innovations not only in the clinical arena, but actually working upstream as structures. And this is another schematic to sort of introduce you guys again to the concept of structural intersectionality. Because if we think about these different systems, right, we see inequitable suicide outcomes. We see different populations that have disproportionate suicide related outcomes. And so we really need to sort of think about these structures that for many people who have multiple oppressive and marginalized identity statuses have worse suicide outcomes. And so this concept of structural intersectionality, right, really sort of brings that home. So it's thinking about structures and spaces, right, such as the child welfare system, such as the juvenile legal system, where the oppression and marginalization is amplified. And it's particularly amplified for those who are the most marginalized. So we'll come back around that. In addition, thinking ecologically, right? So as we think about innovations and interventions and where those occur, as well as barriers and where those occur, we're thinking across these different systems. And so we're thinking at the individual level, we're thinking at the family, friends, school level, we're thinking at the society level, cultural level, and also what's happening in time. And so as we think about different barriers, there's going to be barriers both personally, interpersonally, across family systems, across schools. And so being innovative is going to require thinking across those areas. In addition, really, this dovetails with the ecological framework, but really thinking in terms of health equity is leveraging these different areas, right? So thinking about how can we leverage relationships and networks? How can we think about individual factors, systems of power to shift patient outcomes? The Structural Racism and Suicide Prevention Systems Framework, this is the paper that came out last summer and really wanted to think about how suicide prevention programming was impacted by structural racism, and was also using the same ecological model that we were talking about around considering how individuals are embedded within systems and structures, right? And are experiencing oppression across these structures. And so we know that racism operates in these different ways, and the impact of racism across these different zones impacts suicide outcomes and access. So if we're thinking about cultural racism as a form of racism and thinking about how that's manifest, right? So cultural racism really manifests as negative attitudes and beliefs around racially and ethnically minoritized populations, and it's embedded in societal values and practices. Well, so how does this live and how does this show up really in different zones? So we think about mental health services. There's a paper that showed that when you live in a state with high levels of cultural racism, this actually impacts the efficacy of psychotherapy services for Black youth, right? In places where schools have higher amounts of cultural racism, there are greater disparities in terms of disciplinary actions that impact and disadvantage Black youth. And then same in crisis care. So there's an over reliance on more punitive, involuntary, and coercive responses that address rather than more therapeutic responses for Black youth. So these are different ways across systems, right, that cultural racism is operative. And we think about institutional racism, again, this is sort of thinking about laws, policies, procedures, and practices, how these are embedded to consolidate power, but also end up impacting mental health across different zones. So we think about mental health services. Mental health services are often provided in ways that can be voluntary, right? But also, if patients are sort of brought through emergency services rather than outpatient services. So many times, unfortunately, some of our more structurally vulnerable populations are not getting preventative care or not getting care in outpatient settings. They're more accessing care through crisis services. And so thinking about the sort of levers in which that they're activating care. And thinking about school settings, we have increased criminalization of disruptive behaviors, the sort of gaze, and we talked about this briefly in the first session, but thinking about schools and what happens in schools and the density of mental health professionals in these places or lack thereof versus the density of law enforcement, how will certain behavior be conceptualized, right? And so the ways in which institutional policies such as exclusionary discipline can be operationalized ends up sending more Black and Brown youth to carceral settings as opposed to mental health settings. And again, this happens in with police presence in schools. And we'll talk more about the school to prison pipeline. Interpersonal racism. So this is really behavioral manifestations of racial or ethnic prejudices during interpersonal exchanges. And so when we think about how does it feel, you've heard the expressions barbecuing while Black, jogging while Black, being in the park while Black or brown. And so the sort of experience of being melanated in different spaces, what is the interaction that you have with mental health services at various stages, right? The person at intake, the emergency department staff, these different interactions often, sadly, are racialized due to everyday discrimination and bias. And so people experience this. So we think about all the different structural layers of racism. This is a way in which racism is showing up in the interactive level, right? So at various points in accessing services, these are ways in which racism shows up, and this can disrupt, right, the capacity to form attachments to providers, attachments just to the notion of getting care, and really can add to the feelings of distrust. If we think about it in school settings, again, school staff may not properly identify suicidality among youth of color, may respond to disruptive behaviors with behavior management or punitive measures as opposed to therapeutic measures, and similarly with crisis care. And so they may, resort to using 911 as opposed to preventative services, which then disproportionately leads to carceral entanglements. And then interpersonal racism really, refers to the sort of internalization of negative attitudes and beliefs about oneself. And so really, if you think about the confluence of these different sort of layers, right, this can aggravate these feelings of discrimination. So people can be, prone to internalize many of these things. And also, there's this sort of feeling of feeling gaslit because often society is not acknowledging a lot of the harms that it does, and particularly at the structural levels that we're talking about. And often these conversations are not highly visible and really naming these structures. So, and many times services really lack the cultural humility as well as the cultural responsiveness. There's not really space, right, for youth to empower themselves and speak their voices around harsh disciplinary action. If they do, they're often subject to retribution. And so there's not really, I'd say the sort of internalization also is somewhat self protective, but it's also emotionally damaging. So let's think about current gaps in treatment. What are some of the barriers that impact pathways to evidence based treatment for BIPOC youth? So we think about barriers, right? And thinking about structural racism as an overarching barrier that operates in these different zones, there's also barriers just to service utilization. That racism is a lever and operates on all of these areas. But just with the everyday person, right? Recognizing the problem. So we can see how problem recognition, what's the perceived need, right? How do we express distress? It can look different in various communities. What are the sort of referral points by gatekeepers? So gatekeepers being people who are part of the behavioral health workforce, school personnel, pediatricians, clergy, all the different zones, child welfare, social service providers, also thinking about sort of knowledge and gaps in services. So all of these sort of are, at the earliest entry point. Then really the decision to seek help. We talked a little bit about the interpersonal racism and the internalization and the mistrust that can impact the decision to seek help, right? What is your interaction, not only with like the interpersonal interactions that you may have had in school may make you wary really of discussing some of the concerns you have. So this is also an important pathway that is a structural barrier. Then thinking about service selection, right? Medication versus therapy, financial, long waiting lists, so the social cultural barriers. So these are all sort of barriers. And then what happens is in the service selection, right? This is an interactive zone where the patient and their caregivers are interacting with the provider. And so the service selection can be, I would say, these social cultural barriers are an overlay on these medication decisions, the therapy decisions, the level of engagement, right? And then thinking about treatment utilization. So, what's the fit and match between patients' needs and the system's availability? We'll see that oftentimes there might be certain types of treatments recommended, certain evidence based protocols, but they might not be available, or the density and the frequency of those services aren't feasible for the family to participate, or the hours in which the provider is available, or the distance. All these different things can impact treatment utilization and adherence and engagement. And I would say that there's a sort of interplay between all of these areas, right? So if you think about just like, I believe I introduced you guys to the concept, or not introduced the concept in this space, to the class standards. So culturally, linguistically appropriate services, and really thinking about language as it pertains to both service selection, decision to seek out treatment utilization and adherence. That's a big issue, right? And so you have to see how none of these are just one off, but often I would say that they unfortunately aggravate and potentiate each other. So oftentimes there's glitches in multiple of these areas that all sort of work together to aggravate desistance from treatment, and particularly around language can be a significant barrier. So when we're thinking about actually seeking help, right? Many times there might be a preference for informal care, right? Some people may prefer to rely on community support and access community support. Some families may just be uncertain about where to access care. The waiting times are really something that's very pressing, and we'll talk a little bit about workforce shortages and location of clinics, and racial incongruity between patient and provider, cost and stigma. And these are also, I'd say, going back to the structural intersectionality piece, these are all sort of aggravated by social determinants of health. So if we think about education, access, and quality, right? What are the services available in the schools? We know that there's gaps in special education and mental health services depending on your school district and your zip code, right? As well as the availability of mental health services and clinics depending on your zip code and social community. So we cannot delink the social determinants of health to some of these decision making pathways. This is an interesting study. It's pretty old now. It's done by a group that actually looked at utilization and barriers to children mental health services. And it's, it estimated that about a third of families who participated in seventh grade interviews indicated a need for services and that they reported a barrier. And really, the barriers were across the board, but really related to structures, and so often, right? Not just structures, but structures were really pertinent. So finding that help was too expensive, that it was inconvenient, location, not knowing where to go, all these sort of things that really fall into the social determinants of health zone. And also this sort of perceptional barrier, right? So either not feeling, that the problem was serious enough. So like the psychoeducation piece, wanting to handle it internally, really barriers related to perceptions of mental health services, negative experiences with professionals, and afraid of what family and friends think. So stigma is a big part of barriers to care as well. So let's talk a little bit about mistrust. It can be challenging for many ethno-racially minoritized groups to access care, and this is not new. And a lot of this is related in the legacy of inequity, structural violence against these communities, right? So it's really, people say, mistrust, distrust, but there's really valid reasons why there is mistrust. And so it can be really challenging to overcome this. And people, rightfully have concerns about this. And so really we see that partially this mistrust also results in gaps in treatment, right? And so not only do we have uh, gaps like related to families just sort of not feeling safe with their providers, but the providers are not diagnosing the youth accurately. So we're seeing across various diagnostic domains that are associated with risk for suicidal behavior, that there's gaps. So whether it's depression, we're seeing significant racial ethnic disparities gaps where Black and Latinx youth they're less likely to be diagnosed and they're less likely to receive treatment. And so both, if you think about the sort of barriers to care, not only are they not getting the diagnoses, but they're also not getting the treatment with the diagnoses. We think about ADHD, which we know also has associations with suicide risk, right? They're less, Black and Latinx children are less likely to be diagnosed with ADHD than white children, and also white children are more likely to receive treatment. And so this matters, right? If we think about school settings and the type of services that you get, because schools are an important source of they're an important therapeutic setting for youth who have behavioral health disorders. And so part of the diagnosis often manifests in the school environment. So if it's being missed, it's a problem. Also, there's racial ethnic disparities reflected in choice of treatment methods, right? So again, we're seeing that prescription medications there are gaps for Black, Asian, and Hispanic youth. So I want to talk a little bit about workforce shortage, because really, as a child psychiatrist, this is a huge issue. In California, for example, like a third of California's population lives in a psychiatrist shortage area. And this graph, this map actually shows some of the sort of high and low priority areas. But you can see that, and there's been articles that actually look at workforce shortage specifically. Sorry, I moved this. But basically, more than half of the children in the United States with a treatable mental health disorder do not receive treatment from a mental health professional, which is staggering. And there was one stat I learned that there are about 9 child psychiatrists for every 100,000 kids. And so, even though the number of psychiatrists, child psychiatrists, has grown, still 70% of US counties had no child psychiatrists, and they're much less prevalent in low income and less educated communities. And so, if we think about how to address suicide, right, for BIPOC youth, and we see a racialized and economic distribution to this very important resource of workforce, right? And I didn't look at it for psychologists or LCSWs or LMFTs, but there is a lower density, of providers in these states. And so this actually looked at the numbers of child psychiatrists relative to the population. And really, the numbers, they are growing, right? But we are still too low. And so it's been really aggravated in areas that are more rural, that and also have higher numbers of ethno-racially minoritized patients. And really, if we think about rural communities as a specific zone for inequity, and really impacted by structural determinants of health, and thinking about really like Native American population, some Latino population, and Black populations, and parts of southern states, Midwest, really rural communities are having really high rates of suicide. And so there's certain structural barriers that impact their ability to access mental health services that are a confluence of these different structural determinants. So one is basically, fear, stigma, right? But there's concerns about that, but just there's fewer healthcare resources than those found in urban communities. There's transportation limitations. There's also digital inequities. So there's often a lack of broadband, and the capacity of the healthcare system in most rural communities has been in steady decline for years. And so there's been more closing of rural hospitals and clinics. And so this is causing a shortage. And so these communities are atrophying from behavioral health services, right? And so the rates are actually getting higher, and particularly from certain types of suicide deaths. So we've seen that the leading mechanism of suicide for youth age 10 to 19 living in least populous areas was firearms, 56% in rural communities, which is higher than the overall group rate of 46%, as well as thinking about opioids. And so thinking about the sort of easier access to lethal means, and also less legislation around lethal means and prescription drug use in those communities. And so again, thinking about policies, procedures, practices, and programs, and legislative issues, that this is an area. Okay. Thinking about schools as another zone. So each year, school consists of about 6,000 waking hours, and the average American child spends around 1,000 of them in school, which is, I learned this actually I was at my child psychiatry conference recently, and a pediatrician stood up and was talking about how much contact time they have. And that was really incredible, how critical schools are really as a micro system, and how needed they are, right, as a setting and as a structure to leverage. But we have really significant gaps, right? So we think about it. There's comps and no counselors in so many different areas, and there's just really kind of large disconnect between the presence of need, right? Record levels of depression and anxiety, like that's coexisting alongside multiple forms of trauma for our youth, but they're in schools that are under resourced. So we already saw kind of geographic the maps, like the density of child psychiatrists, the workforce shortages. But let's just think about this, right? 1.7 million students are in schools with police but no counselors. 3 million students are in schools with police but no nurses. 6 million students are in schools with police but no school psychologists. 10 million students are in schools with police but no social workers. And 14 million students are in schools with police but no counselor, nurse, psychologist, or social workers. So we need a higher density of behavioral health workforce, or just even allied health professionals in schools. And thinking about schools as a structure and space for not only it's a space where there can be harm or a healing, right? And really structurally, what needs to happen in terms of workforce density in those spaces is really critical. And the reasons, we don't, it's very dangerous. So many schools do not meet the recommended ratios for psychologists to students or counselors to students. And it's estimated that in this academic year, or no, we're in the last academic year, only like 20% of public schools actually had vacancies for mental health professionals. That's 1 out of 5 schools. And that 85% thought it'd be very difficult to fill these positions. And then if we think about geographically the location of those areas, right? Not only like in urban zones, they're sort of, in neighborhoods that have higher social vulnerability index. This is where there's also lower gaps. So rural areas as well as neighborhoods in urban areas with higher social vulnerability index. And so, according to the Department of Education, this is a recent survey, it really showed this sort of disconnect, right, between the need and what's available. So only, whereas 96% of public schools offer at least some mental health services, only like around half of them say that they're effectively able to provide it to all students in need. And so we see this across the board in terms of, they don't have enough staff. There's inadequate access to licensed mental health professionals. Funding is a concern. Lack of community support. So these are all sort of really primarily in the structural zone. Okay. Stigma and barriers to access. So what are some stigmas faced by youth from different racial ethnic groups? And, these are not all of the stigmas. I don't think different ethno-racially minoritized groups are a monolithic blob. There's so much variation. And so I'm giving that sort of preamble disclaimer caveat. But I wanted to just sort of introduce some aspects of cultural stigma related to groups, and that it's worth exploring these. And so discrimination and racism matters in terms of stigma, and perceptions around discrimination matters. And so research has suggested that there's an intergenerational link between how parents perceive discrimination and child mental health outcomes. And this may extend to suicidality, but this also just extends to mistrust, right? Distrust, level of engagement, willingness to, in that early sort of chronology along the continuum of service utilization, decision to seek care. And so stigma and concerns around being worried about feeling discriminated is a barrier, right? Also, despite this need, and want to, like an acknowledgement of having mental health concerns, there's stigma in Latino culture around both machismo and marianismo. And so thinking about the sort of role of women and being family centered, the sort of self sacrifice, chastity, which are stereotypes, but those sort of are dominant themes that are internalized in ways that keep people from seeking care. Similar in Black communities, there's this notion pull yourself up by your bootstraps, like access the church. These are ways in which stigmas sort of dictate for some families ways and access to seeking care. The API community is also not a monolith, right? But there are cultural stigmas that dog all of our communities. And one of the things about thinking about mental health challenges is often viewed, and I would say this is fairly cross cutting around several BIPOC communities, as an individual problem or weakness, right? So somehow, if you are feeling sad, depressed, anxious, it's some sort of moral failing, and the pressure to achieve, to be successful, and the stress of that, and not sort of rising to that challenge, there's concerns about weakness, and this can be a barrier to care. The notion of historical trauma, disenfranchisement, marginalization, and cultural assimilation are also barriers for Native and Alaskan youth, in addition to sort of just geographic distance. So thinking about systems involved youth. So systems involvement really speaks to youth who are in the juvenile, legal, child welfare, and public behavioral systems, and they often have multiple risk factors for suicide and have higher suicide rates than non-juvenile, legal, non-child welfare involved populations. But there's a gap in terms of their treatment need and treatment receipt. And so thinking about this gap, 79% of white youth receive mental health services compared to 59% of API, 64% of Black, and 70% of Latino youth. And so if we're thinking about barriers and removing barriers and structures, we need to sort of think about addressing those structural barriers specifically in those systems. Similarly, thinking about intersectionality and structural intersectionality with LGBTQIA plus populations. More than 54% of LGBTQIA youth who reported wanting mental health care in the last year did not receive it. And a lot of this is related to structural barriers. So not only interpersonally not feeling safe, but structural barriers in terms of not feeling like someone would provide care, understand their gender identity, also knowing where to access service, inability to afford services. The Trevor Project has a really excellent report on this. And so this, I'm gonna just move quickly through it, but just like, what do providers think in terms of, you know, the structural barriers not only are on the patient and caregiver end, and we sort of explored that, but really thinking about us as providers, and you know, how do we sort of how does some of these structural issues impact us? And so really, workforce burnout, lack of resources, often our services are really insufficient. Many people don't feel like they have enough case management support. They, you know, for people who are non-psychiatrists, it's really hard to get a psychiatrist to be part of your case planning team. Insufficiencies in training. People are taking time out for this training, but really to keep on top of the literature. Fragmentation in the organization will cascade. How do you access service? The wait times are very frustrating for the providers who want to maybe get their patient in an IOP program. So we, as providers, experience structural barriers as well that impact all aspects of the behavioral health cascade and impact our sort of well-being and sense of, and our you know, potential to mitigate moral injury. Also, we're observing these sort of larger structural zones where we're seeing inequality. We're seeing having to like sort of send families who do not have enough support. And so we're often not able to intervene. There's not tools that we're given actually to intervene in some of the areas, some of the structural areas, because the way our sort of current health system is set up, it's really not modeled in a way that's community focused, right? So much of the clinical encounter is occurring in a, an office that's really delinked from the ecosystem of the patient's life. And so if we sort of reimagining care, how can we think about these other sort of areas and innovate there? And so really in summary is thinking about like, how do we kind of really think about schools, right? And think about other settings like clinical settings, but expanding the notion of what it means to provide care and having more community-based solutions that are also community engaged, relying on both youth, caregivers, families to be more centered in the process and leveraging different community assets. Also thinking about training a workforce so that they feel more ready and able to navigate the different organizational barriers. Also, we need to sort of think about workforce, right? There needs to be a really bolus of workforce development initiatives because we have a severe shortage. And so, I'm sorry, I want to go back to this. And then also in the next webinar, Dr. Meza is going to talk about culturally attuned, culturally humble, and culturally responsive practices and that are anti-racist in nature. And so I want to add the sort of overarching preamble that thinking about structures and thinking upstream is an anti-racist framework. And we hope that you're understanding that our lens is explicitly anti-racist in sort of naming the root causes of these different structures, but speaks more specifically about different interventions that are specifically anti-racist and race affirming in the next webinar. And that really, in summary, is just like recognizing that the barriers are structural and we need to sort of move to remove them. And that in doing this, we're going to stop weird science. And so we talked about this concept that Joseph Henrich, he developed in 2010 to talk about that most of our studies and interventions in behavioral science are on weird people, Western educated, industrialized, rich democracies, but these represent, 85% of the population. And so they're weird. They're just not, their outliers are not, they represent, less than 12% of the population. So this is not the dominant population. So we need to move from weird to real, where we're race conscious, equity focused, equity minded, accessible, accountable, and linguistically concordant. So I'm excited to hear from my colleague in talking about that in the coming weeks. And thank you. And we would like you to scan this QR code or copy the link, which will be in the chat. And now we're going to go for the Q&A section.
Great. Thank you, Dr. Bath. Let me turn on my camera. And if people can add their questions to the Q&A portion of the Zoom, should be below right next to the caption section and the share screen. Dr. Bath, can you hear me? There we are.
I can hear you.
On the spotlight. Thank you for sharing.
Yeah, should I stop share now or leave the QR code up? We can leave it
I
up.
think we can leave it up while people are scanning and completing the questionnaire. And also, this is also a reminder for people to add your questions on. If it's hard to do it on the Q&A section, you can put it on the chat, and I'll just read them along. there were a few questions that we had for you that we wanted you to elevate and expand upon. So you mentioned the barriers that exist to specifically suicide treatment, which is already so highly specialized, and we know very little about what treatments actually work. Currently, only DBT has received the most empirical support for its efficacy in reducing suicide risk. So my question to you, given your clinical and research expertise is, how do you think that social structures like the child welfare system and the juvenile legal system add to the existing barriers to care that are already there?
I think they potentiate the sort of gap. If we think about the journey of many youth who are in the child welfare system, many of them are experiencing separation, they're experiencing displacement, disruption, right? Movement, right? Just think about, I don't know, like we have 115 participants, so we can't do a lot of like chat, but how many people are caregivers, right? How many people have to get their, kids or family members to doctor's appointments? That's hard, period, right? But imagine if there's no caregiver, or the caregivers are fragmented or being removed, and just keeping track of the appointments, right? And imagine if that appointment needs to be, 12 sessions at a certain clinic at a certain time. I mean, so those sort of the movements in child welfare when someone's removed from the home, because what happens in the life of a youth who's removed from their home due to, concerns, suspected or confirmed maltreatment, is really tricky. Sometimes they move schools, right? Sometimes they move to a completely different neighborhood. And so there's often a fragmentation that happens that disrupts their whole treatment trajectory. I mean, one of the things, one of my first jobs out of training was working for the Administration for Children's Services. It was the ACS Bellevue Mental Health Services. And so next to Bellevue Hospital was the ACS building, which was New York City's child welfare building. And so it was a shelter. And any time a kid would get removed for abuse or neglect, and there wasn't a place to put them, they would come sleep at the shelter. So we had babies to 21-year-olds, and some kids would be there for just a couple of hours. Some would be there for months. But it was really related to placement. And my boss at the time had the foresight to put a mental health team there in situ. I say this because when kids would arrive, the reason why they put a mental health team there is because when kids are being removed from the home, no one knows they're not getting a nice little bag packed with all their, oftentimes, sadly, with their meds. Sometimes the removals are very chaotic, traumatic. There's arguing, right? And so you can't be organized, unfortunately. The caseworkers are sometimes going into hostile environments, and it's hostile and violent to remove someone's kid. And so that ends up impacting the care, right? There's going to be a disruption if they're enrolled in some DBT. They might have been living in Brooklyn, now they're living in the Bronx, right? Geographically very far. And by the time the new foster family gets up to speed, and they may have other foster kids, right? Even getting that information, kids don't have a digital passport with their care team, right? And so those are some of the reasons. Those are just structural, logistical. They're not any really good reasons. They're just kind of silly logistical reasons. It's almost like trains in the timetable. And similar, like thinking about just keeping a kid's IEP together, right? Yeah. Moving schools, but all those things are related, but they also, I think, exacerbate the morbidity of the illness. And so then they're getting less services, more fragmentation, more delayed care. So the system is oppressively impacting the outcome, right? And it's delaying services, it's making the services less robust. Yeah.
And
And
I
same for kids in the carceral setting, right? They're like, they're released, they're detained, they're,
there's so many, like you said, disruptions to their care, which even for kids that are not systems involved, it's already such a long journey to find evidence-based care and receive it. And one of the things that I hear you saying is that in addition to those structural things that are disruptive, a lot of youth really do rely on a caregiver or a parent to get into care. For kids that are in child welfare and juvenile legal systems, they sometimes don't have that relationship with a primary caregiver, right? So what adult in their life can be that protective seatbelt to get them into care? And I think it's even more important for suicide, because one of the main common elements for suicide to be effective is that it needs to integrate a caregiver, or else it's not robust. It doesn't have sustained effects. So how can we overcome that, like you said, logistic barrier of not having sometimes that primary caregiver or parent to facilitate access to care? Do you have any, I don't know, innovative solutions on how that can happen?
well, yeah, and a couple of things. I think these systems, right? Dorothy Roberts, who's a legal scholar, writes about the child welfare system as the family policing system. And so, because of the disproportionate impact on Black and Brown, and particularly Native American families in terms of the separation, because families in those systems like often lack agency. So it's not that, like, so the parent or the caregiver who would be that caring contact, right? Who would be that person to ensure the follow-up, etc. They are often disenfranchised of their rights, right? So they don't have even a lot of times that separation process, they're losing their rights to even exercise that, maintain that connection in a way. Do you know what I mean? And so it's very disenfranchising. It's quite awful, and it's not like they don't care, right? They may have, and again, if we think about most of the times, like, and we'll just sidebar on this child welfare issue, but most of the times it's neglect that is the most common form of child maltreatment, and neglect is often related to concentrated poverty. So, and poverty is weaponized, right? The people who experience the most concentrated poverty are Black and Native American people and Latino people, right? And that's structural, right? That's due to racism and all these other factors. And so most caseworkers don't have the ability to buy a bunch of groceries when they go into a house and see there's no food, but they can remove a kid, right? Think about all the costs and the cascade and the disruptions, to that removal. And so the erosion of that contact, I think there's a structural intervention there, because is it better? I mean, certainly if we're not going to be abolitionists and work with the system we have, then there should be some fidelity. If a kid is already enrolled in treatment, like whoever that caseworker is needs to be responsible, or the system needs to support that caseworker, because the caseworkers are very overwhelmed, but knowing like what is the existing care plan, and not also having disruptions in the caseworker, right? Because there's a lot of changeover too. So, little Jenny may have 3 or 4 caseworkers. I think they try to do things to mitigate that disruption, but you could have a consistent adult attachment figure in these systems, at least child, but that's also a structural issue that this organization doesn't set up. Do you see what I'm saying? And it erodes the familial structure. I would say even more so in the juvenile legal system, there's a lot of attorney turnover, it's not the fault of the attorneys, and probation turnover as well, and then also separation from families. If we think about where detention facilities are located, how they're far from families, what's the level of family engagement while kids are detained? But it is possible, right? to sort of meaningfully include families, right? And design more family centered systems, which probably would not have these systems at all.
Yeah. And I wonder if people can share in the chat how they've been able to integrate other caring adults into care when sometimes that primary caregiver or parent is not available, because I think that's where we have to get creative in how we provide care as, you know, psychologists, psychiatrists, or social workers. And one thing that I want to think out loud with you, Dr. Bath, is that in the suicide literature, we know that nominating a mentor in your life, not a parent, but a mentor, a trusted adult that you can reach out to when you have you know, high suicide risk or you're in crisis, that has been really effective in preventing suicide. And when we look at the juvenile justice literature, having a mentor has also been very effective in keeping keeping these kids you know, in care and not recidivating. So is there a way that you think that we can integrate both of these areas and I don't know, be more innovative in the care that we provide, either through mentorship or through you know, nominating caring adults?
I mean, I wonder if there's, you know, again, I think structurally, what if there was a policy, right? That if kids are going to be just like we, there's a policy that kids get representation in the legal system. You have the right to an attorney, right? Well, maybe part of that is like you have like a mentor, you know. Now, there's many states you can get a court appointed special advocate, a CASA, right? But that's usually like a little extra thing that people have to apply for. It's not part and parcel of the experience of being navigating through the legal system, but it would be so frame shifting and radical and structural, right? If every kid got appointed like a
Yes.
CASA mentor, period. Do
How
you know what I
amazing
mean?
would that be?
Yeah, like, and that mentor would just be the sort of central brain steward of whatever, like mental health, school, like some sort of single repository. And, you know, many times a lot of families are still involved with their kid. You know what I mean? So they could just help the families. And if there's not families involved, they could help, you know, on that end, but they would just, you know, serve the need. But that's not, so I would say it would have to be at a policy level, right?
Yeah.
To have something like that in place systematically, right? Not the one-offs. Because there are programs like that that exist, but it's not like every kid gets it. And like many of us are healthcare professionals, so we're maxed out, but like imagine how many like are we all volunteering to do this type of work, right? So there's a lack of like workforce sort of working at the policy level to think about these things, speak about these things, come up with interventions. We're seeing how the fragmentation impacts, do you know what I mean? But we are not, are we like co-writing? I was joking with Shabnam and Aaron the other day, like we should actually at the end of these sessions, like maybe write a policy brief.
Yes.
Crowdsourcer, you know what I mean? So that we do something actionable
Yeah.
from this, right?
Yeah, I love that you always go back to the structures, right? Like, how do we impact or change these structures? And you just said something that I think was so powerful, which is how do we, as ourselves, what role do we play in holding our systems accountable? Almost everyone here today, you know, it's either a social worker, or a teacher, or a psychologist. We all are part of a system, and we're just keeping it real, right? We're all part of a larger system. And in webinar 4, I'm going to discuss how this cultural consciousness continuum at the very upstream of that continuum is something that we call cultural safety. Part of developing cultural safety is that you have to use your power to hold systems accountable. So my question to you is, how can all of us here on the webinar today hold the systems that we're embedded in accountable?
Well, I think, we talk about, like, in our earlier slides, right, Jocelyn, we talk about leveraging our positionality,
Mm,
right? So, for example, you and we get to present to this esteemed audience. That's a privilege, right? And there's a certain power doing that. So, what ideas are we sharing, or what spaces we get to operate in as a child and forensic psychiatrist who's working both at UCLA and in the court system? I have a certain amount of power in
yeah,
being able to be in those spaces. And so often, so how am I using that to help, advance equity? So I think everyone doing their own sort of privileged positionality check and seeing what their sphere of influence is, um, and creating sort of, using that privilege to like advance conversations, because there are a lot of ways that, we can do really big things. I mean, I've had that experience in Los Angeles County, just not feeling like I had a lot of power, but then recognizing that there's actually not that many child psychiatrists who are working in the court system, or child psychologists, and just being able to show up, work across, with probation, work with attorneys, public defenders, district attorneys, judges, like, and really sort of provide psychoeducation. It was really impactful to some of youth trajectories, people thinking differently about trauma, thinking differently. And so there's different ways that people can innovate in their space. If you're observing, if you work at a clinic and you're observing, I think I had the slide talking about sort of organizational culture, where you're
mhm,
observing, antiquated policies around wait times, or, and you think about ways to like make it better, or piloting, speak up. Many times, the best solutions are going to come from the people who are, I believe in the for us bias. So the people most impacted, the workers, are going to know what's up, right? And so really not being afraid to actually come up with those solutions, but working within your sphere to create more space for those who are most marginalized.
yeah. I love that. And sometimes the first step is to call things out, like you said, antiquated policies. I think you and I have been really frustrated by our system not taking Medi-Cal,
Yes.
UCLA, and sometimes just calling that out. Like, why are we in the middle of LA and not taking Medi-Cal? Why are we not providing services for low income families that we could be doing, right? And sometimes I think it just calling those things out and bringing it and centering it into the conversation is a step in the right direction of holding the systems that we're in accountable, so that we don't burn out, right? Because sometimes it could lead to burnout as clinicians or researchers, to be in a system that we feel is not responding to the needs and the crisis that we're living in with the mental health crisis.
Yeah, and to piggyback on that, so like, you've exposed me to some of the literature on student activism, right? And positive mental health outcomes and lower suicide risk for college students. And I would say that I definitely have, in my academic career, which has been around like 20 years or so, have definitely experienced more joy in the pursuit of
Mm,
justice. Um,
yes.
I've been in these roles that I get to think about justice, right? And so, in being more activist oriented, in being in affinity spaces and talking about, I mean, Jedi work is very exhausting. So Jedi is the acronym for Justice, Equity, Diversity, Inclusion. Sometimes you'll hear EDI, Equity, Diversity, Inclusion, or Diversity, Equity, Inclusion. But this sort of work where you're thinking about policies, procedures, practices, programs, thinking about, barriers, health equity, that work is really exhausting, but it also feels activating for me. And I definitely have felt, and there's an Audre Lorde quote that talks about like your silence will not protect you, right? So it's like does not, it's really not helpful. It
Yes.
may feel comforting, sort of, but it's going to persist. And one of the things I've definitely witnessed the powerfulness of collective voices and collective action. So some of our trainees in psychiatry, in the School of Medicine, in psychology have organized with the faculty. Some of the faculty have organized, and we've actually changed some of the policies, procedures, and practices at the medical school level that are to make them more affirming, to make them more equitable, to make them more just. So whether it's having more payer blind acceptance, so we changed some aspects of the IMD exclusion. So now in our inpatient setting, we can accept Medi-Cal patients on the adult unit. That was huge. That was the result of a lot of activism amongst faculty and students for several years, just sort of pushing together, and so this is a notion of just like sort of you see something, say something, work across lines, right? It was a lot of cross racial alliances, which is so sorely needed right now. And we did it. We established so much infrastructure in health equity structures, right? We didn't have a health equity lead in the hospital. Now we do. We have a vice dean of JEDI. Now every department has a JEDI lead. It has JEDI committees. So there's a lot more infrastructure than doing more work. And so I do feel like there's hope in doing that. And I would also say, like, thinking about it more broadly, like thinking about how can schools and other settings support, because if we think about leveraging community spaces, how do we support youth activism, right? There's a lot of really interesting work thinking about youth participatory action research, youth being involved in social justice movements, and particularly for ethno-racially minoritized youth, thinking about that as a facet of both racial pride affirming activities, but just getting them involved, whether it's registering to vote, thinking about things like Roe v. Wade and reproductive justice, getting youth involved and their sense of agency, even creating PSAs for 988 campaigns. Like, how can that really help them have agency in terms of their behavioral health outcomes? And imagine if we can sort of work at levels to impact that, create different types of clinical spaces. Like, yes, we need group therapy, but what if we could do group therapy that would support them in loving legislators, right? Teaching them different type of practical skills.
Yes. And when I talk about, I'll be talking more about this, like civic engagement, youth participatory action research as a suicide prevention framework. And I think doing that allows us to cope more actively, right? Not from a colonized approach of dealing with these issues from a more passive way. So I want to move on to a question that was asked in the Q&A, and I'm going to read it out loud. It's from Therese. I have seen clients being lost under the care of commissioner due to changes in caseworkers. How do we prevent or minimize this? It's a great question, Therese.
I think so Dr. Meza said earlier about this sort of the single person, this one mentor. I mean, this is a problem. I saw this when I worked in child welfare. I see this now that I work in juvenile legal system. Like, I wonder if as a policy that there's this sort of continuity of care model. In health, we think about it, right? That someone shouldn't have a bunch of disruptions to their therapist, to their doctor, right? That there's something beneficial and therapeutic about having the same provider over time, right? You build the rapport, all the things, right? But we don't apply that same framework in child welfare for caseworkers. There's so much movement. And then think about all the information that gets lost, the trauma of having to tell the story again. And then just the fragmentation of the care. And so I feel like that requires a structural intervention, right? And I don't know, I'm not educated what's happening in New York City around that challenge, and if people, how people are naming that challenge, but what is put in place to ensure continuity of care of caseworkers as kids are being moved through systems. Maybe there's a rule that there should no more than 2 caseworkers. And I mean, I don't know, I'm spitballing here and I want it to be more evidence based, so I should be quiet. But like, I don't know what is the sort of sweet spot. They should just have one. If they can have one in their whole, uh, lifetime of being involved in the child welfare system, that would be ideal, right? Or a
Um,
team that knows them, right? And also have their information kind of digitally saved so that people aren't reinventing the wheel. So that if I get Johnny, I'm going to know that his, mental health is here, that these are the current meds, that it's always updated in real time, and that the family has access to it. Like, my fantasy was always to create some sort of app. And if anyone's from Google, like, holler at me, but some sort of app, right? Where it's on demand access to all the information that the parents, caregivers, and the youth can have too. Because sometimes and who their caseworker is, because sometimes the caseworker changes and someone new shows up and the youth doesn't know, the family doesn't know. I mean, there's a lot of time lost, and it's very dehumanizing not to have that basic information that controls your movement and your displacement and your sense of attachment, right?
So like
And so this is
integrating
why,
information.
yeah, but this is why Dorothy Roberts talks about it as family policing, and there's no legal representation that protects those caregivers. You know what I
Yeah.
mean? So we've argued, some of us, like, there's a civil rights issue here. I mean, and that's a different structural thing, but I think the sort of lost and changes in caseworkers, that needs, at the commissioner level, speaking about it in a structural way. Like, what would be the structural intervention? Like a one caseworker policy.
Yeah.
I don't know. That sounds really rigid, right? So there's probably some nuances, but sort of moving towards this continuity of care model because of all the things they're already experiencing, disrupted attachments, right?
Yeah. Yeah. And it looks like Arlene has a question. Her hand has been up. So I don't know if Arlene, you can unmute yourself and ask your question, or if you want to put it on the chat. While we wait, I want to give Ismael a shout out, and he gave us an alternative term instead of mentor, which sometimes feels like it's very hierarchical, to use the term transformational partner, which kind of levels things. So I wanted to give Ismael a shout out for doing that.
I love that term. Yeah, yeah.
And
And
Arlene,
also,
you are able to unmute yourself. If you can hear us, you can unmute yourself.
yeah, so maybe put it in the chat if you can't. It looks like she put it down. Allison, when we were talking about calling out structural inequities, she also mentioned how it's important to purposefully use your power and to stay connected with yourself and utilize your voice in bigger ways. So yes, Allison, we're in agreement with that. While we wait for Arlene, I don't know if she can go off camera or off mute to ask her question. I think one of the things that you mentioned a few times and that everyone here is struggling with is that sometimes we want to see more families. Sometimes we really do want to provide more care, but we're already stretched so thin. We have increasingly longer and longer wait lists for all the clinics. So there is really a shortage in mental health providers. So what are some of the things that you're currently doing or some strategies that you have on how we can build the mental health workforce? Hopefully making it more diverse, right? In as a way to be able to prevent the further widening of this crisis.
Well, I think redefining who counts as workforce. So expanding that narrative to be more inclusive of people, like community assets, right? So there's a lot of people who can enhance mental and emotional, social emotional well-being for youth and their families that are beyond people who are credentialed like us, but they're
Yeah.
not necessarily empowered and positioned to do so. And so how can we sort of create systems that support and augment, so people with lived experience, people like, clergy, people like expanding like that, you know, who we consider part of behavioral health workforce. Also, thinking about like youth mental health ambassadors, right? Community mental health workers, promoters, all those different sort of zones like are not really optimized. And even when they do have programs with community health workers, they're often there's a big glass ceiling, right? So those workers often don't have the ability to um, have career advancement at the
Yeah.
most senior rank. So creating more pathways
Yeah.
for advancement and just more opportunities that also involve youth. So
Yeah.
one of the things that's happening in Los Angeles, right? Department of Mental Health is partnering with LA Trust and this LA Unified to increase youth sort of behavioral health ambassadors, right? And so youth are learning about mental health basics, and really they're going to be able to serve in some sort of capacity as sort of wellness council. But imagine that's another sort of way of activating youth, thinking about clubs like Bring Change to Mind, or like the program we're involved with, Jocelyn Youth Mental Health Academy through Child Mind Institute. So really thinking about how to enfranchise youth with these different skills so that they can also be part of the behavioral health workforce. And then also our pediatric colleagues, right? So a lot of models are really thinking about co-locating behavioral health services in family practice office and pediatrician's office, and like not only providing them telehealth consultation services to behavioral health clinicians, but also actually having the providers there in situ to help. And so we need all of those, right? Because of the gap. I mean, 9, let's call it 10, because that data map looked at it from up to like 2017. So let's say we have 10 child psychiatrists for 100,000 kids. That's nuts, right? And we're all basically in LA, New York, Philly, there's so many gaps, right? And like child psychologists, y'all are the same as us. Like all the mental health professionals, social workers, all of us are concentrated in highly educated, high SES, more elite centers, right? It's the
Yeah.
same, like zip codes determine health outcomes. So we need to expand the who, right? Like, and the narrative of the who, which is going to include other people who aren't credentialed, and also some of the allied providers, right? So peds, family medicine, and like increase their mental health literacy, which is really about stigma also.
Yes. Yeah. You're getting some comments on the chat to really reinforce a lot of the conversation that we're having. And one thing that I think we need to think about, because we are in structures that sometimes are more likely to serve a certain community, is to think about how can we widen our reach by building capacity with community members. So one of the things that I have been doing in my clinic is I offer a CBT for depression group in Spanish. Is free for anyone that can attend. And what I'm seeing is that a lot of the women that are showing up, they're educating other members in the community, like depression is a real thing. It's not just in our head. Like, let's talk about it. They're destigmatizing. So each week we have new people coming to group, people that are wanting to get services. And now what we're going to do is we're going to have the people that graduate from the group lead another group in the community. So it's one thing, how can we build capacity with our community members? We can't be the sole gatekeepers of providing services.
And
right?
who are the most credible messengers, right?
Community.
Like, but that's an example of using your positionality. Like, you can create the space, you have the snacks, you can create, like, you can send out the email listserv, like, you have access to all these tools, right, to create the zone. And then you're empowering them to do that. And they need to hear it. I was saying, even in terms of thinking about our curriculum and how we teach about behavioral health disorders, like, is it only sufficient to read a zillion peer review articles? It's not helpful. I mean, it is, but we need
Right.
to hear from people with lived experience, people who are helping people with lived experience, all the things. And so decentering, like, what counts as knowledge, who counts as producers of knowledge, and recognizing that it's going to exist in many forms.
Right, exactly. And also meeting the community where they're at, right? Not just providing services in clinic, but thinking about community settings. Like for us, we provide services in the public library as a way to meeting families where they're at.
Yes,
Therese,
both in terms of setting and in terms of, like, people, right?
in
And
people
so
and setting, exactly. We have a really good question by Therese, and she also made a really good comment on how we need more integrated and reverse integrated sites to increase access to care youth. And her question, or their question, is how do we decrease caseloads while increasing pay to decrease the number of clinicians leaving CBOs to going to private practice or leaving the field altogether? Preach.
I mean, I don't be like, it's structural, like, which is above my, like, pay grade. I mean, yeah, there's not parity, right? In terms of what parity between psychologists, psychiatrists, LMFTs, LCSWs for same services. Also, just the notion of, like, how long it takes to see, just because you see someone for 50 minutes, right, is way more time that's spent. And the documentation, people are dying, right, under the electronic health record. It's supposed to make things, I mean, if we think about oppressive structures, the EHR, electronic health records, is one of them in some ways, and just keeping in track. And so I don't know, but we do need to address remuneration
Yes.
gaps. I think caseloads, I think naming some of the invisible work and quantifying it. But I know when people try to document all of the extra things they do, like with the CPT codes, that's exhausting and takes a zillion years. And they're like, oh my God. So I don't know, but there's a lot of moral injury. I think the fact that these sort of systems are, can I speak to more how the EHR is an oppressive system? I think the burden of documentation can be really exhausting for, I know, at least talking to a lot of physician colleagues, that they feel that it's really the charting is really onerous. And there's a lot of, and particularly sometimes when people are in publicly funded clinics, there's even more treatment planning. There's these sort of long forms that need to be filled out electronically that don't necessarily feel as meaningful or capture the time spent with the patient and their caregivers, right? Or just some of the different structural things that might need to be done, like signing someone up for housing or going with them, right? Like that, with the demands of the charting can be very time intensive, navigating that EHR. So, and I don't know, I don't think it's just me who feels like the EHR can be kind of draining and time intensive from when you could just, I don't say like scribble a note, but it's different
Especially
sort of,
especially
documentation.
when you're working with families that are in multiple systems and really integrating that into one node, right? It's really it's challenging. So everyone, Shabnam just put some links to some New York Credible Messenger links so that everyone can have those resources. Dr. Bath, we are at time, but thank you for always speaking your truth and sharing your wisdom with everyone. We appreciate you.
Oh, and thank you, Hani, for said that she feels put the push out. Yeah, the
I mean,
documentation.
you need to come back to webinar 4 so we can continue that discussion on feeling that you're being pushed out and the sense of belongingness as clinicians in a field that doesn't always feel very welcoming.
Yeah, and I would, there's a lot of, I believe, literature on the burnout and electronic health records and documentation. And I would send that to your folks, Honey, and also accommodations.
Yeah. So we're going to be sharing the slides with everyone as well as the recording. And we hope that we can see everyone at webinar 4, where we are really going to hone in on culturally responsive treatments for suicide that you can integrate into your own care, to your own clinics. Thank you, everyone.